Hello, and thank you.
Recording in progress.
Thank you for joining me. I'm Louisa Clarke, and I am going to be talking about some subjects that are really quite close to me and of great interest to me. I'm going to be talking about some of the latest biomimetic toothpastes that we can use and talk to our patients about, but with robust scientific evidence behind them. So we all have patients that are coming in to see us on a daily basis. Some of them have different wants and needs. We are using the better dental guidelines. However, some patients don't want to use fluoride, some want vegan, some want, need some without SLS. So I'm just going to be looking at some of those things and how we can inform our patients and also know that we're actually giving them a good evidence-based pace to meet their needs. So before I get started, just going to give you a little bit of information about who I am and why I'm talking to you about this. I'm a dental hygienist. I've been qualified for over 23 years now. I started with my diploma from the Eastman Hospital. And then also after I had my children, I came out of clinic for a little while when I decided I was going to top up and start looking at some other bits and pieces to do with dentistry and top my diploma up to my BSc in dental studies at UCLan. And it was here that I really started to look at scientific papers and scientific evidence and learn how to really critically appraise papers and find out what it is that I was looking for. With that in mind, when COVID hit and we all put our scalers down and needed to come out of clinic, I took the chance to actually look at where I wanted to go next in my career. And I was accepted onto my master's in oral biology at Queen Mary's, which was a lab-based master's, which took me into the labs then where certain toothpastes were being developed, certain active ingredients were being looked at. Part of my research thesis then was to look at polygamma glutamic acid, which, although we're not finding those in toothpaste and mouthwash yet, they're in the pipeline, they're in the post. Lots of research is being done behind them. And that led then to some of my research being incorporated in the paper you see on the left-hand side. So enamel and enamel protectants, although I'm a hygienist and my training is very perio-focused, has always been a big interest to me also. I then went on and got my postgraduate diploma in clinical education, and now I am very happy to be one of the tutor hygienists at the Eastman, teaching on the BSc dental hygiene and dental therapy programs too. There I am, standing next to a very hot plate, dissolving hydroxyapatite one very hot summer, just to prove that I did put that work in. Okay. So before we get looking at toothpaste and toothpaste ingredients, it's really important to have a little recap on our dental tissues, our dental hard tissues. These are the ones that we're trying to protect. We'll all have done these in our undergrad studies, but sometimes just a little recap kind of helps us when we're going on then looking at some of the science further down the line. So what we're looking at here is dental enamel. Dental enamel is an amazing tissue. It's a nano composite and it's made up in a hierarchical structure. So we start from tiny little crystallites that then make rods and prisms to then start making these big tissues. And it all works together to help protect against the chemical, thermal, and physical properties and stresses that we have in our mouths on a daily basis. We know that enamel is acellular. So whatever you were born with, whatever your teeth erupt as, is pretty much what you get for the rest of your life. And we're all living longer now and need to keep these until we're hopefully 99 plus. It's an inorganic tissue. We know that. It's 96% hydroxyapatite crystals, 3% organic material, which is usually the remnants of amelogenin and some of the proteins then involved in amelogenesis, and then 1% water. So it really is dehydrated tissue. Here's what we're looking at. So if we look at that hierarchy I was just referring to, the little purple hexagon that you can see on the right-hand side is the crystallite. And it's knowing what's going on in that crystallite, which is so tiny. It's only 70 nanometers in width and 25 nanometers in length. And they come together and they're held together by some of the proteins. And that forms rods and prisms to go throughout the entire tissue to make it structurally as strong as possible. And you can see then as we go from the purple little crystallite, it's almost like Lego, we're making then parallel and divergent rods and prisms all come together into a pattern 2 enamel, which we find in human enamel, but we also find in bovine enamel as well, which is really important for research purposes. So we can actually use both of those, and we know that the physical properties and chemical properties are going to be very, very similar. And then all of that goes to make up the enamel that we see and have in our mouths, that we see on the crown of our teeth. There it is, looking at human enamel through the scanning electron microscope. Again, you can see that keyhole shape and all those little kind of amazing little crystallites then all forming bulk of the tissue. So going back to that little purple hexagonal unit that we looked at in the last couple of slides, if we were to take that and now put it on its side so it's looking directly at you, this is how it's made up. And it's understanding these ions and how they interact with each other is how then we can go and look at some of the biomimetic toothpaste to work on this molecular level. So if we start with the outer ring, we've got 6 calcium ions that form the hexagon. We then have a triangle of calcium ions on the inside that make the triangle of a star, and 60 degrees in turn with that of the phosphate ions. And right down the middle, we then have a row of hydroxyl ions, so an oxygen and hydrogen together. And that's really important because it's that row down the middle, we call that the C-axis of the crystallite. Down that C-axis is where a lot of the interaction is going to be, then weakens or strengthens the enamel as it goes through these thermal, physical, and chemical changes. So if we're going to take that crystallite now, and we're going to stand it up on its end. And these are how the crystallites all come together to form the rods and prisms. So the C-axis, rather than looking down the camera at you, is now standing vertically. And all the ions then are electrically forming together to give us a full kind of a prism. So almost like a tessellation, they are standing up and against each other to give us a really strong structure then for the prism. Moving on to dentine. So dentine, although very close in proximity to enamel, is a completely different tissue. It comes from a very, very different embryological origin. So where enamel is ectodermal and therefore has no nerves or blood supply, dentine does. It's from the mesoderm. So we have a rich blood supply, a rich nervous system as well, which means that it can repair itself. So dentine is also a hydroxyapatite. The hydroxyapatite in dentine, though, is forming a network of collagen fibers, type 1 collagen. And in it, we know that we have tubules as well. So it can repair itself, as we know. The hydroxyapatite isn't in crystallite form. It's in little flat oval forms. And when we look at the structure of dentine, we have the tubules that run from the inside of the pulp chamber out to the outer surface of the tissue, which is usually in health covered by gingiva. However, we know patients get recession through periodontal disease, abfraction, lots of different reasons, exposing then the tubules at the surface. Now, this is a very, very exaggerated diagram of odontoblasts sitting in the pulp chamber, and their process is then going down into the tubule. But what's important to see here is that we have fluid in the tubes. And if you can see at the very edges of the tubules, we always have a lighter colour dentine. So the tubules are hydroxyapatite on collagen. However, the lighter colour peritubular, so lining the inside of the tubule, is a really highly mineralized dentine, which has no collagen in it. So it's very kind of similar when it comes to the molecules in that area, the ions in that area, as enamel. And we use that to our advantage. So peritubular dentine is highly mineralized and has no collagen fibers. That's what it looks like under a scanning electron microscope. So you can see you've got your intertubular dentine, you can see the open tubules, and the highly white area that you can see surrounding the tubule is the peritubular dentine. So how do we protect these tissues? Okay, we have this amazing biofluid that we all take pretty much for granted. In health, we as humans produce 1.5 litres a day. And there's so much in the saliva. Obviously, it's water-based, but we have carbonates in it to buffer acids, we have immunoglobulins, we have enzymes such as amylase to start the digestive system, process. However, when it comes to protecting the hard tissues, the fact that it is super saturated in calcium ions is what we need. That's what we're looking at here. And if anybody has a dry mouth for various different reasons, such as medications or immunological problems such as Sjogren's or head and neck cancer treatments, you'll see that very, very quickly the hard tissues start to break down. So by doing something or finding some products that have a very similar mechanism as saliva, then we're able to help our patients. So how does saliva help? Well, the first thing it does is it lays down the acquired enamel pellicle, the AEP. And it's the salivary proteins then that are in the saliva that bind onto the C-axis of the enamel crystallites that we looked at previously. So it's all happening on that C-axis, mainly on the calcium ions and the hydroxyl group. So the salivary proteins, they're selective. The first one that is going to bind onto the enamel is phosphoprotein called staphyrin. Now, staphyrin is made up in the acina glands of the parotid gland. And if we don't have staphyrin, then the AEP does not develop and we have an exposed enamel to the elements, to anything then that is being put into the mouth or coming up from the stomach. So we need the primary one as staphyrin. And once staphyrin then has absorbed onto the enamel, we then get other proteins then absorbing onto that as the next layers. And these are histatin and proline-rich protein. These are really important because what they do is act as a reservoir for the calcium ions that are in the saliva. And they hold it next to the enamel. So when we have that dynamic interaction, when pH drops and we have the calcium leaching out of the crystallite, we have a ready supply of calcium then in the pellicle that then goes straight back into the tooth again. And we have this equilibrium, a balanced equation going in and out constantly for our enamel. So this is what it looks like. In A, we've cleaned the enamel surface. There's nothing on there. This is very much the case after an air polishing technique. So we have a very clean enamel surface. And then straight away, as soon as the saliva comes into the mouth, then we have the absorption of staphyrin, followed by the other proteins, as you can see in B. And then that starts to build up. We get other proteins and we start getting then our glycoproteins and other, lipids and carbohydrates then that form biofilm. And from that, then they'll get colonization of the bacteria. So this is staphyrin. Okay, staphyrin is that phosphoprotein I've just discussed. It's only really small, this protein. It's only 43 amino acid bases or residues long. And we now know there's lots of research about staphyrin, but we now know, as I say, if it's not there, if it's not present in the saliva, a pellicle does not form. So it binds electrostatically onto the C-axis, onto the calcium and phosphate and the hydroxyl on the C-axis of that crystallite. Okay. It does that because it has two serine bases, and these serine bases are phosphorylated, so they have a phosphate attached to them. And what that looks like, if you look at the bottom of the screen over here, you'll see a big long line of letters. Each one of these represents an amino acid residue or base. And if you see at number 2 and number 3, there's an orange PS. That means phosphorylated serine. After that, then we've got 2 blue E's, which is glutamic acid. That's also needed, and that's where my research sat, looking at the glutamic acid. But then if you follow it up to number 13, there's a yellow R, and that represents arginine. Now, at the moment, we don't know why, but if that isn't there, if that arginine is not there at number 13, staphyrin does not bond to the tooth. And there's lots of research going on with this as well. So keep in mind the phosphorylated serine, glutamic acid, and the arginine as we go through this lecture. And that's just a representation. You don't have to understand this equation at all. You don't have to be chemists. This is a representation of that constant ionic interaction, dynamic interaction between pellicle and the ions in the pellicle and the enamel surface. And in health and with a healthy saliva, we're able to make sure that we don't tip the balance one way over the other. Okay, so if you can see on one side, we've got calcium phosphates and the hydroxyl group in saliva. And then on the other side, we've got exactly the same. We've got our calcium phosphates and the hydroxyl group in the enamel. And this is a constant interplay. And as long as we don't set that, we don't go on and have a disease process. This is caries. Unfortunately, it's still something that we are seeing every day. It's one of the most prevalent diseases still in man and especially in childhood. We've all seen this, we've all studied this, unfortunately, but we know that there's more to it than just having a tooth, frequency of fermentable carbohydrates, time and bacteria, although they're the major core of the disease. We also know there's so many different factors, and part of that is saliva, what's happening with the saliva, if it's a whole saliva or if it's compromised. And there will be a time where we will be doing saliva testing, not to do with the oral microbiome, which is happening in some labs now, looking more at the quality, looking at the calcium, looking at what's happening, looking at staphyrin in people's saliva. There was one, I believe, by GC. Don't quote me on that. It was one of the manufacturers, but it was very, very expensive, and therefore the uptake was very poor. However, I think in the near future we'll start doing some whole saliva testing on patients, especially those who have been through polypharmacy, head and neck cancers, and the like. So when we have our patients in the chair, we're already, looking at their teeth and assessing that. We're using the IKTA scale. Okay, so looking to assess where we're at where it comes to healthy enamel or early white spot lesions, right the way through down to the cavitated enamel and into the dentine, and scoring that. And by doing our assessments, especially on patients that we deem high risk, looking at their diet, doing proper full diet analysis, potentially saliva testing when that comes to, we're able to intervene then and hopefully prevent demineralization and promote remineralization in codes 1 and 2 before they cavitate any further. So here we are, we're looking at white spot lesions here, incipient caries. These are lesions that are demineralized and they haven't crossed the CEJ yet, so they're not into dentine. At this point, there's so much that can be done as long as we catch it early and we educate our patients and we get them on board with what we're trying to do. Okay, can be mineralized, and we've seen some excellent results with it. The most important thing, though, to do is not pick up your probe, and I'm sure all of us as clinicians know that, but it's just a little reminder. We do not probe these areas, and we need to be really careful as well what we're doing on the surface there. It wouldn't be something I would put a particularly large particle air polisher on either. Going back to your uni days again, just have a little look at the histological features of a white spot lesion. So it hasn't cavitated. You can see these lesions here in the pictures and the images are not into the dentine. And we can see that really lovely mineralized surface zone. Underneath it, we have the body of the lesion. And then we also then look at our translucent zone, which is the advancing edge, and the dark zone that sits directly behind that. And all of these different zones, they've lost mineral and they have different amounts of pores now in them and pore sizes as well. And the idea now is if we can get something that penetrates into the body of the lesion, we can start to build it up again. And that's how a lot of these biomimetic toothpastes work. Unfortunately, we're seeing this more and more. We're seeing rampant root caries. When it gets to this level, it's still the one thing in dentistry that we find very, very difficult to treat. We're seeing it more in elderly patients because they have a drier mouth due to polypharmacy, and they're the people who are likely to have more gingival recession. So these are the patients that we really need to try and find something that's easy that they can use on a daily basis to help remineralize areas and stop it from cavitating at all or further if it started. Unfortunately, we're also seeing a lot more of dental erosion as well. People are changing their diets. We're seeing a lot more of fruit drinks, smoothies, health conscious people, lots of juices. And then, we've seen the teenagers still drinking fizzy drinks, and including in that now is also gym drinks as well. I have a 16-year-old son who likes cans of Monster, which is a a battle I'm still trying to win at the moment. We're seeing more and more erosion on the teeth. It's the irreversible loss of the mineral on the teeth, enamel and dentine. Normally happens at pH 2 to 4. And again, once the enamel is weakened, we're then adding on mechanical forces when we're eating, chewing, speaking, and certainly brushing immediately afterwards. So that's all adding to the effects then of the enamel and dentine loss. Looking at dentine hypersensitivity, this is still the theory we use. It's the hydrodynamic theory, where we have a stimulus, whether that's chemical, mechanical, or thermal. The fluid then moves in the tube. It's picked up by the processes and the nerves then on the odontoblasts, and we perceive it as pain. And still to this day, by trying to block those tubules and block them efficiently so they stay blocked, will stop the fluid from moving and the patient no longer perceives pain. So finally, we'll move on to toothpastes. So we're all using toothpaste. Thankfully, it's the one thing, certainly in the Western world, that most patients who are brushing their teeth will use. It's not like trying to ask your patient to all of a sudden start using a water flosser or something new to them. Most patients know toothpaste and are using something or other in their mouth twice a day. However, are all toothpaste equal? So when I qualified, I pretty much knew that obviously we used fluoride toothpastes and we were going to use them twice a day, and you brush for at least 2 minutes and you spit, don't rinse. And this is still part of the DBOH guidelines, delivering better oral health guidelines. However, I also came away with the message that all toothpastes needed to be 1,450 parts per million of fluoride, that it didn't matter what the fluoride was that was in the toothpaste, and preferably the toothpaste needed to be without any SLS. And when reps used to come to the practice, they were the first questions I used to ask. And it's only now with these newer toothpastes that I'm starting to challenge those last 3 points. Absolutely, we need to brush for 2 minutes twice a day and spit the toothpaste out, but don't rinse. However, the others, I think we can challenge a little bit. So we need to cater for our patients' specific needs. And I'm seeing more and more patients now that are coming into practice and they don't want to use fluoride for whatever reason. They've heard things on TikTok, they've heard things on social media, they've read themselves, and they're looking for alternatives. They also don't want to use SLS because they've heard and read things about that. And there's some other, whether they're vegan, they want to know if it's a vegan. So patients are becoming a lot more clued up and want to know a lot more. And as hygienists and therapists, they're going to be turning to us for the answers. And it's their right, it's everyone's right to ask these questions and to know more about what they are choosing to put into their bodies. And it doesn't always mirror with what we know and what we say as a profession, certainly when it comes to fluoride. Now, I use fluoride. I use fluoride in my own mouth. I use fluoride in my children's mouth as well. However, I do understand that people are aware that it's a neurotoxin in large quantities and may want to stay away from that. Okay, let's have a little look at some of the active ingredients, the non-active ingredients that every toothpaste will have, and they need to have them to make the paste that work well in the oral cavity. So every toothpaste will have a form of abrasive. It needs this because, as well as the action of the toothbrush bristles, we need something to get a little bit kind of deeper and start to sort of disrupt the pellicle and the biofilm that's formed on the teeth. And this is usually silica, which is a tiny glass particle, or sodium bicarbonate or calcium carbonate. And again, we need to be careful that these aren't too abrasive. Every toothpaste will have a score on the RDA, the relative dentine abrasive scale. We want that to be 70 or below. Well, sodium bicarbonate toothpaste, although they feel really gritty when you're using them, sodium bicarbonate breaks down really well and really quickly in the mouth, so the particle doesn't stay large for a long time. So as an abrasive, it's really very good, although it feels as though it's really, really going to be too abrasive for the enamel. We all need surfactants in our toothpaste. So surfactants help to have the foaming action, and that's what's going to spread the active ingredients far into the oral cavity and cover all of the surfaces of the teeth and in between the teeth. We also need humectants. So humectants keep the paste from drying out. Some of the humectants being used are glycerol, sorbitol, propylene glycol. They're usual, but we need those. We're now starting to find that some of the more biomimetic, hyaluronic acid and that sort of humectant is being used as well. We also need binders. These are our xanthan gum and carrageenan, which comes from seaweed, and the cellulose, and this binds everything together, again, to stop it from drying out and becoming very powdery. And we also use colouring agents. The super white colour that everybody knows and is synonymous with toothpaste comes from titanium dioxide. And this, again, is a controversial ingredient along with sodium lauryl sulfate because it has been had links again on social media very much at the moment with being a carcinogenic or causing hypersensitivity in some patients. So to date, going back to what I was saying about fluoride, we still very much need fluoride. It's still the only product and only iron that is licensed for caries and caries prevention in the UK. We use it in different concentrations depending on how we assess our patients. So obviously, if we've got a high-risk patient, we're going to be using Durafat varnish on the patient, still with a prescription, unless we've done our exemptions training. And that's 22,600 parts per million. And we also then have the fluoride toothpastes at 5,000 parts per million. So what's fluoride and these four images of these people got in common? You may ask yourself, why have I made this slide? The reason we use fluoride and the reason it works so effectively is, in my opinion, that it's very, very attractive. Okay, which I think these four lovely people certainly are. Whether we use sodium fluoride, stannous fluoride, or sodium monofluorophosphate, there is an instant and immediate electrostatic attraction to the ion that is in the enamel. It's in the crystallite. Okay, so as soon as we put that on the teeth, it's instantaneous, very, very attractive. But what does the fluoride do? Okay, you remember this again from your undergrad lectures. What it does is knock out the hydroxyl group that's sitting in the C-axis of the enamel crystallite. And because it's so attractive, it knocks the hydroxyl out and immediately fits into the C-axis. And that changes our hydroxyapatite to fluorapatite. What that means is where we have the critical pH, where hydroxyapatite starts to dissolve at pH 5.5, because the fluoride ion is larger and a lot more attractive, it takes a stronger acid to start breaking it down. So our critical pH then is lowered pH 4. And that's why we use fluoride. And to this date, we don't have anything else that does that within the enamel crystallite. Fluoride also can remain in the enamel pellicle in small concentrations, so it's not cleared away orally. So the toothpaste, when we say spit, don't rinse, normally clears after about 20 minutes. However, the fluoride will also be bound up in the pellicle and the biofilm, in the channels of the biofilm as well. It also increases the smoothness and the microhardness of the enamel surface, so the tooth becomes smoother, it's easier to keep it clean. And also, if we've got areas where, we're getting any kind of crack propagation, it helps to strengthen that as well, where pH occlusion isn't necessarily class 1. However, because it's so attractive and it's so instantaneous, the fluoride only is used by the surface of the enamel. Okay, it cannot penetrate any deeper. It's a large ion and it's gone straight into the surface. And it's one of the reasons we get the surface zone then on the white spot lesion. Everything underneath it is starting to disappear. So fluoride cannot penetrate deeply into the enamel substructure and into the cavitated lesion. Okay. So this is it. This is exactly what I was explaining to you. So on the right-hand side, you'll find fluorapatite on the left-hand side. You've got the hydroxyapatite. So you can see the fluoride fits exactly down the middle of that C-axis in the middle of the crystallite. Really strong, okay, really, really strong bond there over the hydroxyapatite. So it takes more acid to be able to break that down. Hence critical pH of 4. So let's look at caries prevention toothpastes. Going back to the DBOH guidelines, okay, we know the concentrations that work well, okay, and that one aren't going to cause any problems for our patients. However, we also know what are actually going to have the therapeutic dose to help our patients in prevention and remineralization. So with the guidelines state that we use 1,000 parts per million for children and adults who have a healthy whole saliva. And then we need to up that for older patients because the polypharmacy that we're seeing and the drier mouths that we're seeing in older patients. But then for children that are high caries risks, we use 1,350 parts per million and then raise that to 5,000 parts per million in adults who have a high susceptibility of root caries. However, are all fluoride toothpaste equal? Well, the answer to that is no. So according to the evidence and the huge body of evidence, stannous fluoride comes out on top when included into toothpaste. So standard fluoride at a 0.45% concentration, we know strengthens enamel and it has an antimicrobial effect as well. So you're going to be seeing these in the new Colgate Total toothpaste that's been released recently. I've used this myself and I find it very good. I like the way it makes my teeth feel for a long, long time after brushing. And then the Oral-B Pro Expert as well. So stannous fluoride in all of the papers comes up as the better one for both of those reasons. So what else can we use? We've looked at fluoride. That's our usual protective measure, sorry. However, what else can we use? What are we going to be looking at in the biomimetic toothpaste? And what do we suggest for patients who don't necessarily want fluoride? Excuse me. So the first thing we're going to look at is tooth mousse. It's been around for quite some time now. It is a casein phosphoprotein, amorphous calcium phosphate. Okay, so phosphoprotein we've heard before. Okay, when I was discussing stathin, that's a phosphoprotein. So we have the phosphorylated serines. So what tooth mousse is, it works in a very, very similar way. It's a phosphoprotein that has come from casein, which is a dairy product. And this in itself also works in the same way and binds onto the C-axis of the enamel crystallites. So when it was first developed, it came without any fluoride in it, and that's tooth mousse that you can see on the screen here. And then they also then incorporated fluoride for that surface, the outer surface, and that's MI paste. And we use the two in practice quite regularly. This is what I use after I've done any kind of air polishing. I will put a smear of this on my patient's teeth afterwards. It comes in lots of lovely flavours and is accepted by most patients, especially children. I use this a lot on any student, any patient, then child who has MIH, molar incisor hyperplasia. It cannot be used with people though who have a dairy allergy. This is the mode of action. Okay, so it penetrates into the white spot lesion. Okay, it binds onto the tooth surface and it uses that same binding then, as I say, onto the C-axis. So you can see at the top there, you've got phosphorylated serine that we've seen before in stathin. We've got glutamic acid residues, and in it then is an amorphous calcium phosphate. So it hasn't got any structure to it. It's not crystalline. And it's that then that binds onto the tooth enamel and the calcium and the phosphates pass into the substructure. Whilst that's happening, it also helps to neutralize the pH as well in an area where it's fallen below 5.5. So you've got GC tooth mousse. You've also got something very similar that's new, relatively new, about the last sort of 5-10 years by Curacept, and this is their version. So this is biosmalto. It's the shop action mousse. Now biosmalto means it's the Italian word for bio, and smalto is enamel. Okay, this again is an amorphous calcium phosphate, but it does have fluoride in it this time. And how they've used it is at the bottom, you can see the round circle. That's one of the particles. And they've actually wrapped it in citrate. So this one isn't using casein, so it can be used by everybody, not including people who have dairy allergy. So this is good for everyone as long as they're happy with fluoride. They've added carbonate into this one, and that helps it with its solubility. So it breaks down a lot easier to get where it needs to almost instantaneously, releasing the calcium and the phosphate, which settle then onto the surface, bind onto the surface, and produce more hydroxyapatite on the surface and in the substruction of the lesion. So there's no casein in this one. So these work really well, the mousses. They're used mainly professionally in clinic, although patients can buy them and use them at home. This I use in support with one of the other toothpastes for the patient. So if I'm using any of the other toothpastes that we're going to discuss, I will use this in the clinic and discuss it with my patients there. So why don't we just put hydroxyapatite in toothpaste? Okay, and this is a bit of a buzz at the moment. The last two pastes that I've just been discussing have the calcium and phosphate within the paste, and they rely on them being released in the oral cavity to produce hydroxyapatite and produce that on the surface of the enamel and also in the substructure. So why don't we just go straight in and use hydroxyapatite in toothpastes? Okay, they're becoming more and more popular. They haven't been that available in the UK, and I'll explain that in a little while. However, they're really popular in Japan, they're really popular in Italy, and they're really popular on the other side of the pond in America and Canada. And that's where you'll find most of the research papers on these. So they're toothpastes that contain hydroxyapatite. Okay. Hydroxyapatite comes in three forms, and you'll hear it discussed as nanohydroxyapatite, which has really small particles, microhydroxyapatite, which has larger particles, and then biomimetic hydroxyapatite, which is a synthetic hydroxyapatite that is more similar to the hydroxyapatite we find in our enamel. It binds to the enamel and the dentine, and it aids mineralization. So it plugs those holes in the white spot lesions that we were just talking about. And the calcium and phosphate ions also then remain in the plaque fluid as well. There has been a controversy about it, which is why it's only recently kind of coming onto our markets and we're talking about it. Okay. It was developed by NASA and it's used by the astronauts in the 1970s. And then Japan took that up. So it's widely used in Japan and Italy instead of fluorides. They don't use fluoride in their hydroxyapatite toothpastes. Controversy I was referring to, though, was the hydroxyapatite particles haven't always been regulated. So certainly when we're talking about the nanohydroxyapatite, they could come in any kind of shape or size as long as they fell into nano. And they could, or there was research then that suggested that they were able to cross the brain blood barrier and cause problems then in other organs of the system. So there was a ban then in the UK, certainly for nanohydroxyapatite toothpaste in the whole of Europe, until they were able to look at regulating these and doing a lot more scientific research on the effects it may have systemically for humans. However, after a large body of evidence, okay, there was proven that hydroxyapatite is safe to use in the nano form. However, these particles need to be rod-shaped, not needle-shaped. Concentration needs to be 10% or below, and the particles were not coated in anything or their surface modified in any way. And there's a huge long paper, okay, the one with the green tick underneath, the Scientific Committee on Consumer Safety looked at this, and in 2023 deemed this to be safe. So you'll find that any of the nanohydroxyapatite toothpaste that we now use in the UK will adhere to these rules. One of them is the Curacept Biosmalto range. So again, this goes hand in hand with the shock mousse that we were looking at, the amorphous calcium phosphate. This is a fluorohydroxyapatite, so it does have fluoride in it, but it also has magnesium and strontium in it as well. and also chitosan. So it's in a biopolymer chitosan, which is synthetic in this one, but originally came from crustaceans and their shells. So again, it's all looking at this biomineralization. And it works really well with sodium monofluoride phosphate. There is no SLS in this, and it is also vegan as well. They have a huge range. Okay, so they have the tooth mousse that we were looking at, the shock action mousse, as well as the toothpaste then for the patient to take home. And the evidence behind this is really exciting, huge body of evidence and works really well. There's also a mouthwash as well, but I don't have time to go into that one, which kind of supports. However, the toothpaste action is more the preventive um, products that we need to be discussing. Another one that we get in the UK that uses microhydroxyapatite. So the particles are larger. Okay, they do still work in the same way, but they don't actually penetrate the substructure of the lesion as well. Is Zing, and this comes in lots of lovely flavors. It has no SLS in it and it has no titanium dioxide in it. And the sodium, the fluoride is a sodium fluoride concentration of 1450 parts per million. This also has added papain in it, which is an enzyme that comes from papaya and really helps with staining as well. It's vegan, and they have a huge campaign at the moment where they are singing the benefits of using Zing. You can see at the bottom, their campaign has a particular name, and they're running really with the fact that without the SLS and the titanium dioxide and all very natural occurring apart from the sodium fluoride that they've added, that they are helping their patients to be a little bit more health conscious. We also have Tooth Angel. I've included this one because it's actually been formulated by a UK dentist who is a friend of mine, very passionate about this. And I've also read the papers that he's sent me on this. This again is using a microhydroxyapatite toothpaste, the sodium fluoride 1450 part per million. Again, it's SLS free and it's BPA free as well, and it's vegan. They also have a range of products that go alongside this, including hydroxyapatite coated floss, and all of their toothbrushes as well. They're very environmentally minded. So this tube is completely biodegradable, along with their toothbrushes as well, where I have one here, where it's recycled plastic in the handle, and the toothbrush head then just pops out here when you need to change the bristles, and you use the handle time and time again. Okay. Other brands that we can get in the UK, I haven't used these ones personally myself. These ones use biomimetic hydroxyapatite particles, so they're synthesized in the lab. They're the correct size, the correct shape. They haven't been coated, they adhere to the regulations we were talking to earlier. They have no fluoride in them. They have no SLS. They rely solely on remineralizing the tooth enamel rather than strengthening it and reducing the critical pH to 4. There's no titanium oxide in it, dioxide, sorry, and it's completely vegan. I haven't read the papers on these, but I think they're worth discussing. We see this coming up a lot in social media. There's no evidence to support still to this date, though, about probiotics in toothpastes, and they use this a lot in their marketing. However, the evidence isn't there to support the claims regarding how it changes the microbiome. So that's something that needs to be considered. Okay, so moving on from hydroxyapatite, looking at bioactive glasses. So bioactive glasses, I didn't really know what all of this meant when I first started looking at toothpastes. To me, as a layperson, the idea of glass was very much what we're seeing on the screen here. You know, we made bottles out of it, we were able to stain it, we were able to shape it into different shapes then and drink our wine from it. However, bioactive glasses are silica, and we've come across that when we were talking about abrasives already. And we're able to heat the silica up and do different things with it and incorporate different ions into it and give it different properties depending on how we heat it up, how we mold it, how we cool it down again. So with the stained glass window, for instance, we're able to use colours in the glass and use it for different purposes. And part of that then is also looking at toothpastes. We first started using bioactive glasses in one of the wars. They found that it bound very, very well onto bone, which again is hydroxyapatite, and helped then when it broke down in bodily fluids to help with reforming bones and recasting and resetting bones. They also used it in hip joints and joint replacement. The reason it works really well is that glass is an amorphous structure, very much like our amorphous calcium phosphates we were talking about, an amorphous glass structure. And you can see here the image. So you've got your silica, okay, and your oxygen, and it's kind of a nice sort of lacy pattern. And in between the holes then of the lace, we're able to bind ions. Now, when it's bioactive, we're able to use that and manipulate that property. So with bioactive glasses, as soon as you put them into a bodily fluid, they start to break down. The silica rings start to break down, and it releases ions when we need them the most. So with bioactive glass, it binds onto the enamel and dentine, and then it's slowly dissolved. Okay, over 8 to 12 hours, it's slowly dissolved, releasing the ions when we need them. During that time, when it is dissolving, it also helps to neutralize acids as well. So if there's an acidic attack in the mouth, this is accelerated. It increases the acid very, very quickly, quicker than normal saliva, and also releases the ions that are needed at the same time. So really, really clever technology. The main one is Biomin. Biomin came out of Queen Mary's. I think I said at the beginning, this is where I did my master's, and this was one of the reasons I wanted to do it in the lab. Okay. It's a calcium fluorophosphate silicate. So it means it is a silicate that has fluoride, calcium, and phosphates bound within that amorphous structure. Okay. Because it binds onto the teeth and it's slowly released over 8 to 12 hours, doesn't need as much fluoride for that instantaneous effect. So it doesn't need 1450 parts per million. They can reduce the concentration of the fluoride. So this has 530 parts per million, but is slowly released over that 12 hours. It does have SLS as the surfactant. The reason they've used that rather than any of the others is because they can use it in a much lower concentration. SLS doesn't taste of much, so they can use it in a much lower concentration and also a much lower concentration on any flavorings they're going to put in. But it works really well. However, we are aware that some patients are sensitive to it. It also, as I've stated, increases the speed of neutralization of the pH then in the mouth. When we look at the science behind this, okay, Biomin F, so the one with the fluoride in it, after 1 hour, we have a huge amount of fluoride ions still in the mouth. Going all the way down to 24 hours later, we still have fluoride available, bioavailable in the mouth in a patient who hasn't brushed or used any other fluoride. We also use it then in Sensodyne. They use slightly different glass. This time it's Novamin. You'll find it in silk powders, which are for air polishing. It's used in Sensodyne Repair and Protect. So instead of being a calcio fluorophosphate silicate, they use sodium in this one. And although it's excellent, it works in exactly the same way. Because there's sodium in the particle, it makes the particle larger. So it doesn't quite penetrate as deeply into the tubule as Biomin. However, it works really well. And this one is SLS free. So it works in the same way, as I say, SLS free for patients who are concerned about that. Now, moving on slightly to arginine, if you remember when we were talking about statharin and looking at the different bases and their order, arginine was the one at number 13, and we still don't know why, but without that arginine being there, statharin will not bind to the tooth enamel, and there's lots of evidence behind this now and more happening in our labs on a daily basis. What we do know with arginine, though, if it's 1.5%, it's excellent for caries prevention. Okay. And what it does is when it's with fluoride, it suppresses Streptococcus mutans as well in the biofilm. So it's binding onto the enamel and it's suppressing the strep mutants, okay, when it's with fluoride. And the one that has arginine in and works really well is the Colgate Sensitive Pro Relief. We'll also look at sodium bicarbonate. I touched on this very briefly earlier as well when we were looking at some of the abrasives. It's used quite a lot in toothpastes. Although it's quite granular, it's very, very gentle to the tooth because it's really, really soluble. Okay. Because it's an alkali, it's sodium bicarbonate, it does neutralize acids very, very quickly in the mouth. And we know that it actually interferes with macrophage action as well. So not only is it breaking down biofilm, and very, very quickly dispersing all the other active ingredients in the mouth, it's also got an anti-inflammatory effect as well. And it's used in Corsadil toothpaste. So Corsadil toothpaste, although Corsadil is synonymous with chlorhexidine, this toothpaste doesn't have chlorhexidine in it. It uses sodium bicarbonate instead, along with the Arm& Hammer toothpaste and the Kingfisher natural toothpaste as well, come with or without fluoride. Looking at the evidence for xylitol, this is used quite a lot in certain products, not necessarily toothpaste. We have spray toothpaste that's coming onto the market now. I haven't read too much on the evidence behind that one. However, we have used it quite a lot in dry mouth preparations. It's a sugar polyol. It's completely natural. It does reduce the strep mutans count, which is brilliant, and it reduces the lactic acid as well that's being produced by these bacteria. Some of the toothpastes also have fluoride in them. That spray has sodium fluoride, 1450 parts per million. But it's used in extra chewing gum, it's used in the Xylomelt's dry mouth, and it's used in Oraleaf toothpaste as well. So it's a really natural product. Not a huge evidence, well, there's a huge evidence base behind it, but it doesn't really, in some of the umbrella reviews that we've looked at, have as much effect as some of the other things that we've looked at. But it's certainly a really, really good product for patients who want to be a little bit natural, have dry mouth, want to chew on something after an acidic meal. Another one is Dr. Hef's remarkable mints. These were and are produced by two British dentists, Dr. Mike Heffernan and Toby Edward Lunn. They produced these mints with xylitol and green tea in them as well. And they're brilliant after meals and work in exactly the same way. You probably see Mike and Ed and Toby at some of the conferences if you go, and they're brilliant, really interesting to speak to and get your sample on these, but working in a very similar way. So what can we do for dentinal hypersensitivity? Well, still to this day, we need to work on blocking the tubules so that the fluid doesn't move and we don't perceive pain. Okay. Now, the active ingredients that we use in desensitizing toothpaste either block the tubule or they work directly on the nerve, or both. So, occlusion of the tubule, okay. Going back to when we looked at dentine and we were talking about the peritubular dentine, the really mineralized dentine that has no collagen in it, we use that and we use the fact that we can bind all of these calcium phosphates, hydroxyapatites onto highly mineralized tissue like enamel. We can do exactly the same with the peritubular dentine. So we need particles that are small enough to be able to pass into the patent open dentinal tubules and then bind onto the tubule wall. And they then reduce the size of the lumen of the tubule, and the fluid then has more difficulty moving. Sometimes the tubule will block completely, and other times it will really reduce the size then of the tubule. And again, we're still going to get a desensitizing action. We've looked at many of these already. Okay, so we've looked at them for caries and remineralization. However, they also have the same effect then when it comes to blocking the tubules. Okay, so we know that stannous fluoride is excellent for desensitizing. We know that arginine and sensitive relief is as well. The Novamin in silk and in Sensodyne repair and protect, and then also in Biomin as well. So they will obviously remineralize the tooth enamel and a white spot lesion, but they'll also work their way down into the tubule. We also have others that we haven't seen in some of the remineralizing toothpaste. So in desensitizing toothpaste, they'll also add strontium, which is a salt, and that's in the form of chloride or acetate. And that works by occluding the tubules. This was the original Sensodyne was strontium. We don't get that anymore. And then we also add in potassium nitrate, citrate, and chloride as well, which has an immediate effect on the nerve in depolarizing the nerve and reducing then the excitability of the nerve membrane. These are usually added with ingredients that will block the tubules as well. So you very rarely find a toothpaste that just has the strontium or the potassium nitrates and citrates. Looking at one that's specifically for sensitivity is Biomin, but this time it's Biomin C. So rather than being the one with fluoride, which will also help with sensitivity, this one is the one with chloride. So it won't remineralize the teeth in any way. There's no fluoride at the surface. This one's much better for desensitizing. So you'll still get the calcium and the phosphate, which will have an excellent effect on the enamel. However, this comes into its own with sensitivity. There's no fluoride in this, therefore it doesn't strengthen the enamel, as I say, but it's excellent. It will bind onto the hydroxyapatite on the peritubular tubules, and it starts to block it up. Biosmalto also have a sensitive range, very, very similar to their shock action mousse. This time it's slightly different. This time it has fluoride in it and it's hydroxyapatite. They've added strontium into this as well as a salt. This one's SLS free, okay? And it's a nano hydroxyapatite. So it's small enough to get down to the tubules, okay? They've also added fluoride into this, and it's a sodium monofluoride phosphate. They have, again, the huge range of products then. So from the tooth mousse that we use in surgery to this toothpaste that we can send our patients home with, and then also a mouthwash to be used at a different time. What's their sensitivity line? So how do these ingredients compare? Okay. This table came from an excellent paper that was published earlier this year by Jeannie Suvan and Crystal Maraganti. It is looking at all of them and all the scientifically proven ingredients that work and what they work for. So anything that's white, the toothpaste ingredient wasn't investigated for, okay? Anything that is red, okay, means that it had an adverse reaction, potentially. However, anything that's green has clinical evidence to support it. And that's where we need to be going as healthcare professionals to know that we are backing up everything that we have said. So if you look, our first ingredient there is our amorphous calcium phosphate, our casein phosphoprotein. And we know then absolutely the evidence there is supportive for caries, the arginine for caries and dentinal hypersensitivity. And if we go down to our fluoride, we know that it has an effect absolutely proven for caries, which is no surprise, and tooth surface loss. However, interestingly, hydroxyapatite, although it has some evidence to support in caries, dentinal hypersensitivity is where the evidence base is for nano and microhydroxyapatite. Going down the same then for our bioactive glasses, it has Novamin there as the example, and our potassium nitrate. Sodium bicarbonate then that we looked at is good for gum health and malodor, which we didn't discuss. But the stannous fluoride is excellent for gum health, for caries, for dentinal sensitivity, tooth surface loss, and malodor. So looking at all this evidence, we've got a range of products depending on what our patients are seeking. If they want SLS free, then we know that we have certain products that we can recommend with a huge scientific ground. If they want hydroxyapatite, there's some that we can recommend. If they want bioactive glasses, if they want fluoride free, we now know that there are products that we can offer our patients and know they're going to work. So here I am. Okay, that's me treating my poor unfortunate son, quite possibly telling him off about his monster drinking. So to conclude, each patient's dental needs are very, very different, and we must tailor our healthcare then to meet each individual without judgment. Everything we advise must have a strong evidence base behind it. And we all know patients are different, their wants and needs are changing all the time, and one size does not fit all. They're the references to some of the papers that I have discussed. And thank you very much for listening. If there's any questions, please do let Siobhan know. They'll get to me. I'm more than happy to do a Q&A session or answer individual questions if you'd like to get in contact. Thank you very much.
Thank you very much, Louisa. Would you mind if I just share a screen here that just has the... Are you able to see my screen?
Yeah, I can see a lovely picture of Prof. Nabali, Dr. Ratu.
Dr. Ratu. So on the right-hand side is the email, NSK Ikigai at Gmail. So if you have any questions around this webinar, which I'm sure you will, please send them into this email and we'll pass them on to Louisa. We're also quite happy to organise a Q&A session, but I think actually we can do it through the email, Louisa, if you're happy with that. I would just like to tell you about this course with Prof. Nabali and Dr. Ratu. That's happening in September in North London. So Prof. Nabali is going to be doing MIST, which is surgical regeneration, and Dr. Ratu is going to be doing MINST, minimally invasive non-surgical therapy, and that's open to dentists, dental hygienists and therapists. It's an absolutely fantastic course. You'll really like it, and as Barker says, it's really work smarter, not harder. So if you'd like to have a look at that. Louisa, that was absolutely fantastic. Thank you so much. Could I
Thank you. It seems a bit whistle stop. A huge
I'm not sure
topic
why that's
there.
happened, but thank you very much. That's so insightful, and I think people probably need to watch it back a couple of times to take in all that information, but so helpful. So thank you for bringing all that together. I'm just going to stop the recording now.